Hello. Today we're going to talk about cardiovascular dysfunction. This whole PowerPoint slide set will be in two separate audio files. So the first one is going to go over cardiac assessment and all of the cardiac defects that children are born with. And then once that is over, we will be getting closer to heart failure after we touch on surgery. So once we get to heart failure, I'm going to stop the audio and I will pick it back up on another audio file. This one probably will go 45 minutes to an hour. And because of that, I just want to separate it so you guys don't have to sit for like 2 hours with no break. Also, you can feel free to pause it. You can download it onto your computer. It's all good. So also there are some heart drawings that were uploaded into the announcement along with this. If you would like to, you can look at those or color those while we're talking. But we are going to ask you to choose one of the defects and color it in with the red, blue, and purple, and then upload that into discussion questions for the instructor. Either myself or Professor Villanova will go in and put not a question in there, but a statement, and if you can reply and load it there, and we will give you participation points for doing that. Okay, so let's get started. So, cardiac assessment. This is something that is done on all levels for all kinds of reasons, and it's no different for cardiac defects. You will look at health history, inspection, you will auscultate, palpate, and you will also percuss, maybe. Percussion really isn't something that we teach you to do in this particular program because it is a bit of an advanced task. So I seem to have lost my connector here. Okay, health history. So health history includes multiple things, such as family history, what's going on in the family. Are there anybody else in the family? Oh, I'm just struggling to talk here for a minute. Is there another family member that has cardiac defects, or is this something new to this family? You want to talk about, or you want to look at prenatal care. Did the mom drink while she was pregnant? Take drugs, including medications. Some medications are difficult and cause problems just as easily as illicit drugs. So you just want to know a little bit about that. Did she have an infection while she was pregnant? Is this her first pregnancy? Has she had trouble before with children? Also, kids, you want to look at their history. And you also want to look at their feeding issues. Very often, these children will have feeding issues, difficulty feeding, failure to thrive, difficulty breathing while they're trying to eat, things like that. So you want to look at that. Inspection. You obviously want to look at their nutritional state. You want to look at their skin color, chest deformities, unusual pulsations, respiratory pattern, and clubbing of fingers. So when you think about their skin color, you also want to look at their mucous membranes, their nail beds, conjunctiva. Those type of items will tell you whether or not the child is centrally cyanotic. You want to assess their hands and feet and their face. Look for mottling. Are they pale, or do they have ruddiness in their skin tone? You want to look at this child while they're sitting as well as while they're lying down. Does their breathing pattern change? Do they have more trouble breathing when they're laying down as opposed to when they're sitting up? Look at their chest for pulsations. You should not see visibly the child's heart rate. So if you can, that is indicative of a problem. Respiratory pattern, are they retracting? Are they having difficulties breathing? And the clubbed fingers, obviously, you know what that is. Usually you don't see that in children until they're 18 months or 2 years. That comes later on. Okay, let's talk about palpation and percussion in relation to their chest, their abdomen, and their peripheral pulses. So auscultation first. Auscultation, we want to pay attention to the heart sounds. You want to listen with both sides of your stethoscope because you will hear different things with both sides. You want to pay attention to the rhythm. Do you hear anything other than lub-dub in their heart rate? Do you hear something like a murmur? Murmurs can be a whoosh, or it can be a whistle sometimes. It can be a gallop. It can be a click, like when you're snapping a plastic case shut. Or it can also be friction. When you hear friction, that can be a pericardial inflammation. So those are the types of things you're listening for, abnormal sounds. And what is the character of that sound? Some of those things I just talked about. Now you also want to think about palpation. So you want to assess the temperature of their body, trunk and extremities. Is it cool the further out you go? Or is it warm, diaphoretic? You want to check pulses. Are all the pulses equal and strong? Check the feet and compare them. Check the wrists and compare them. Or an infant's brachial pulses and compare them. Blood pressure. There are certain cardiac defects that you want to take the blood pressure in all four extremities. There's a difference very often between upper and lower extremities, and that can indicate cardiac disease, very specific cardiac diseases. We'll talk about that later. You also want to look at cap refill in all four extremities. Cap refill in an infant should be very fast. So if it's not, that's indicative of a problem as well. Diagnostic tests. So you will see them use electrocardiogram and echocardiogram, but also cardiac cath. It's very common in children with possible cardiac defects. So let's talk a little more about cardiac cath. It's an invasive diagnostic procedure. They actually put a needle and thread a tube up into the child's heart. I want to go to the next picture so we can talk about it. So here you can see they went up the aorta into the child's heart. That is really the most direct route and the best way to do this. You can also use the brachial artery, but as you see, when you go, you have to make this curve, and that can be problematic. Sometimes when you're trying to make this curve, it will end up going up the neck here, or down and over and up the neck. And I have seen it on rare occasions go right down the other arm. So it's really much easier if they can do it with a femoral artery than a brachial artery. So once in there, they're going to measure the O2 saturation in the chambers. They're also going to look at the pressure. This is really important to find out what the gradient pressure is in particular. They're going to evaluate the cardiac output. Is it sufficient? Is it too low, too high? Is the heart over full? They will look at structures to see if the structures are correct, if there's missing parts, extra parts, or if things are in the wrong place. And they will also look at blood flow patterns. Is there mixing? Is the blood going where it needs to go to get the oxygen and get rid of the CO2? Sometimes they can do corrective procedures while they're in there. They can sometimes close off a PDA or close off a small ASD. Also, they can do a balloon if they have a coarctation. So there are certain things they can do. They can also do palliative procedures. Okay, so here's a picture of a type of radiology suite where they do cardiac caths. They're actually very closely similar to surgical suites. Pre-op cardiac caths are just that, they're pre-op. But one of the most important things you want for children is an accurate height and weight, especially if you have congestive heart failure involved. So think about that. The child comes in, there's probably edema on board for the child in their face, in their legs. So one of the things you're going to do is get rid of that edema and give them some Lasix and maybe some Dig. So their weight is going to change. Their admission weight is going to be different than their procedural weight. So you always want an accurate height and weight before they go in from that morning. Also, you want to check if they have allergy reactions. Obviously, infants will not, but older kids may have an allergy. And you want to mark their distal pulses so that when you can find them easily when the procedure's over. It's always smart to have these kids to be NPO for 6 to 8 hours, because when they find something they can't fix with the cardiac cath, they may take that child directly to surgery. And then you're always monitoring for signs and symptoms of infection, respiratory maybe, or pericardial infection. You always want to look at these things before you send them, and then of course post-procedure as well. So let's talk a little bit about post-procedure. You want to make sure that that leg where they put the catheter in, always stays straight, at least for 6 hours. 6 hours, 4 to 6 if it's venous, 6 to 8 if it's arterial. Most often they will do an arterial, so that child's going to have to lay straight for a long time. It's really interesting when you try and get a 2-year-old or an 18-month-old or even a 12-month-old to lay flat, have their legs straight for 6 to 8 hours. It's a struggle. So have plenty of things for them to do, have their parents there to keep them busy, have a plan before they go to cardiac cath. You do the usual frequent assessment of vital signs. You want to make sure that you are assessing for bleeding as well. You want to always make sure when you're assessing vital signs for kids, in particular, that you look at the dysrhythmias for dysrhythmias and bradycardias, because these kids will go bradycardic very quickly, and they will also have dysrhythmias. Let's face it, you went into their heart and poked around. Well, you didn't, but someone did. So you kind of poked at and irritated that muscle, and sometimes it spasms, just like all muscles do. So you want to watch for dysrhythmias and bradycardia. You also want to watch their blood pressure for hypotension. These kids will surprise you and bleed out differently than adults. So you want to watch their dressing, make sure the pressure remains as long as that dressing needs to be on there. You do not remove that. The physician does. So make sure that the pressure is tight. If it's not, put something over it and make it tighter so that it stays. And if you see blood, of course, you want to mark it and pay attention. But you want to remember that you also look for blood, not just at the insertion site, but with kids, it will pool underneath them. That's actually true of adults as well. But you want to look underneath these children to make sure that they're not bleeding, because gravity will pull that blood and pool it right underneath their buttocks. Okay, you want to check their peripheral perfusion. Those pulses that you marked will become very important. Are they equal? Are they strong? Are they weak? Is one stronger than the other? You want to compare legs for pulses, color, temperature. Is the catheter site, that leg, more mottled? Is it cooler than the other leg? Always be mindful of what that is. And if you think there's a problem with peripheral perfusion, you can always check with a Doppler, but you should notify your cardiologist. Also, if the child complains of pain, increased pain, you want to think about the fact that, again, oxygen is supplying those cells. And if for some reason the oxygen is not the way it should be and you are losing blood, you're not oxygenating those tissues, and it may be very painful. So if the child has increased pain, you want to check for hemorrhage. Okay. Sorry, I'm going to go let my dog out. I will be right back. So let's talk about the generalities of congenital heart disease. So the exact cause of congenital heart disease is not something we really know. They have tried to connect it to different things like genetics, maternal exposure to toxins, alcohol, chronic illness, infections, multiple various things, but there's no definitive answer as to what it's connected to. Some children with genetic defects like Down syndrome kids or Turner syndrome, they will very often have a congenital defect that pairs with that. If there's a family history, most of them are diagnosed at birth, but not all of them. Some get through. I will tell you, when my mom turned 79, actually it was right before she turned 80, we discovered that she had an ASD that had never been discovered. So, people can compensate for a very long time. The whole goal is to get the child back to as normal anatomy as possible, or not back to, but get them normal anatomy if you can, functioning anatomy if not. So the defects can be in the septal walls and valves, things that don't develop completely. Vessels or valves may be small, narrow, or not there at all. And fetal circulation, the structures may not close. So there is a ductus arteriosus that very often does not close, and that is called a PDA, or patent ductus. There can also be a foraminal valley that does not close. So for now, let's just move forward and see what comes next. Or not. There we go. So there are several different types of disorders. There's increased blood flow, decreased blood flow, obstructive, and mixed. So we're going to talk a little bit about each of those first before we go into the defects. Increased blood flow, really the pressures in the heart are still normal. So the left side of the heart has a higher pressure than the right side. And what happens is blood is shunted from left to right. So there's a very small amount of mixing. But the problem is those defects will increase the blood flow into the heart and back into the lungs. And this can cause problems like congestive heart failure. Okay, disorders with increased blood flow. These are the three most common. Patent ductus arteriosus, or PDA, atrial septal defect, or ASD, and ventricular septal defect, or VSD. Disorders with decreased pulmonary blood flow. So before we were talking about increased pulmonary blood flow, now we're talking about decreased pulmonary blood flow. So tetralogy of Fallot is a multitude of problems. There are four difficulties or problems within the heart. And then there's also tricuspid atresia. Those are the two most common that we're going to discuss. Obstructive disorders. The three we're going to talk about are coarctation of the aorta, aortic stenosis, and pulmonary stenosis. Usually those are small narrowing of vessels, and they're almost always the great vessels or the bigger vessels. Then there's mixed disorders. Transposition of the great vessels, where the two big vessels in the heart are in opposite of where they should be. Truncus arteriosus and hypoplastic left heart syndrome. These three problems can be life-threatening, more so than any of the others if a child is born with these and it's not found quickly. So we're going to go back to increased pulmonary blood flow and talk about a patent ductus arteriosus. So the ductus arteriosus does not close after birth. Very often when a child is born, you will hear a murmur, and it's almost always the ductus arteriosus. It can take about 24 hours to sometimes 72 hours to close. It's more common in premature infants. They don't close right away. And then what happens is the blood flows from the aorta down into the pulmonary artery. There's like a little tunnel that allows that backflow into the pulmonary artery of oxygenated blood that then flows back into the lungs. And this can be problematic. It also increases the workload of the left side of the heart. That can be a big problem as well. So we need to get that closed as long as there's no other heart problems, and we'll talk about that later. There are 2 medications we can use for this, indomethacin and ibuprofen. The most common is indomethacin. And what that does is it will constrict the vessels. But that can be a problem because what happens is it doesn't just constrict that tiny vessel, that tunnel between the aorta and the pulmonary artery. It also constricts all the vessels in the body. So that can be problematic, especially in the GI part. You can sometimes get necrotizing enterocolitis, and we talked about that in class. Because what happens is the vessels constrict, the blood flow doesn't go to where the food is being digested, and that creates all kinds of problems. So if that doesn't work, we then use a cardiac cath to close that off. We can put like a little whirligig or a little coil inside of that tunnel to help it clot and close. Or if that doesn't work, then you can do a ligation using a left thoracotomy. So what happens is they actually do an incision on the child's back, and they go in and they tie off that tunnel tight enough so that it closes. Okay. Atrial septal defect. This is one of the few things that's seen more often in girls than boys. This is what my mom had that we discovered at 79. It is actually a hole or a passageway in the septum. So I'm going to go to the picture and talk about it from the picture. So here you can see, here's the atrial septal defect. Depending on how big that space is, it will depend on the problem. If it's a smaller space, and that's the most common, then it will close on its own over the first 18 months of life. If it does not close by the time the child's 2 or 3, they will have to go in and close it. And they can do a couple of different things. This can also be closed via cardiac catheterization. You can go in there and put another one of those whirligigs or a coil type thing or a patch to close it. If not, they will also go in and do surgery and close it. A small suture. If it's a bigger defect, they may have to do a synthetic patch. Let's see. So with this problem, you can see how the blood will shunt from one side to the other, depending on the pressure and exactly how big that problem is. So usually it shunts from left to right, and it can cause increased blood flow to the lungs. So if you have, because of the higher pressure on the left, it will push some of that oxygenated blood into the unoxygenated blood and will go back to the lungs. So the lungs have already given that blood oxygen, plus it's more blood than what it should be. So it will cause problems by overfilling the lungs with that fluid. It can cause pulmonary hypertension, heart failure, and atrial arrhythmias. So most kids are asymptomatic over the years, but eventually they'll just be really tired. They won't want to do anything. They'll have difficulty breathing on exertion. For my mom, she was having decreased saturations. Her sats would get down into the 80s, and she couldn't breathe, and she was exhausted. They thought she had COPD. But when I looked at some of her symptoms, oxygen did not help this. They're already getting plenty of oxygen because oxygenated blood goes back to the lungs. And some of the symptoms she was having, I recommended they look for an ASD. And lo and behold, there it was. And you would not suspect it in an older person. But the body is a wonderful thing when it comes to compensating. And kids can compensate really easily for an ASD. Okay, let's go forward to a VSD. So again, I'm going to go to the picture, and you can see that it's down here instead of in the atrium, it's in the ventricles, and it's just an opening between. This is also a fairly common congenital heart disease, and it will sometimes spontaneous close. If it does not close by the time a child is 2, they recommend doing something about it so they don't have pulmonary problems. Surgically, they will use Dacron patches or something along those lines if it's too big for a suture. But you have the same problems here that you have with an ASD. Let me go back to that for a second. I feel like there was something else I wanted to say. Nope. Okay. So let's talk about decreased pulmonary blood flow. So these occur because of an obstruction in the blood flow or a narrowing of vessels which cause the obstruction. That's the most common. Pressure in the right side of the heart increases, and the blood always flows from high pressure to low pressure, right? It will always go where it's easiest to go, and it will go through some sort of structural defect. So let's look at some of those. So tetralogy of Fallot. This is very common. This is the one I said earlier has 4 defects. The thing about tetralogy of Fallot is that your NCLEX, they love this defect because, or this congenital heart disease, because it has 4 defects. Lots of things to talk about here. Lots of things for them to look at. So you have a pulmonary stenosis, ventricular septal defect, overriding aorta, and right ventricular hypertrophy. I'm going to go to the picture. So when you look at this picture, you can see some of the issues. Here there's mixing because there's an opening right in front of the aorta that's not in the correct place. So it's sending deoxygenated blood to the body. And here we have, I'm so sorry. We have blood going here and we have blood going here. So it's really problematic. There's a narrowing of that pulmonary valve, this one right here. So not as much blood is going through as it should. There's an obstruction. The overriding aorta is pulling in so much of that mixed blood right there by that ventricular septal defect. And then what happens is the right ventricle becomes very hypertrophied because it has to work so hard to push blood up the aorta, which it is not used to doing, right? It's really not used to it. And you can see that left ventricle is small. They're working really hard to get the blood to go up, but the heart's not functioning properly. Okay, let's go back to the picture of the child. So with this particular problem, they have something called a TET spell, and the child will have blue skin during crying or feeding. And you need to be very specific as to what you do about this. The greater the obstruction, the more cyanotic this child will be. Normally they will have low O2 saturations. You'll usually see a sign at the, on the monitor. I'm okay at 75%. I'm good at 80%. I'm okay at 65%. Whatever they're okay at, the sign will be there. So, but especially in the first few months of life, they become cyanotic when they cry. And that is a problem with gaining weight, feeding. They have all these, they get so tired and they use up all their energy crying and they use up all their energy trying to function. So these infants will have these hypercyanotic episodes or blue TET. They come on suddenly, and it's increased cyanosis, hypoxia, dyspnea, and agitation, mostly because they're crying. So what happens is they have a change in their vascular resistance. So what you can do is to help them out, to get them back to their normal, is tuck up their knees into their chest, fold their arms so their hands are overlapping over their heart, and kind of tuck them up. What this does is it helps that, increases that systemic vascular resistance. And it also helps with the pulmonary blood flow. Now, You will also sometimes have toddlers or small children with the same problem. A little bit harder to tuck them up. Toddlers in particular, you'll find that they intuitively will go down into a squatting position, and they'll just sit there for a minute. And they'll look around, and they'll wait, and they'll wait, and they'll wait. It's really kind of funny. And then all of a sudden they stand back up, they pop up, and they're gone. So it's really cute. We had a 2-year-old who was on the unit for a while, and she would do that. She would run till she couldn't run anymore, and she would squat down, and she would just wait there, kind of la 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 la. And then all of a sudden she'd pop up and she'd move again. We really had to try and keep her from doing that, but she would get away with us once in a while and go out there and run around. So you want to help them with that pulmonary blood flow and that vascular resistance. It's important to remain calm so the child calms down, and teach the parents to do this very same thing that we're talking about when they're at home, and to stay calm, because if they're calm, the child will be calm. Okay, tricuspid atresia. So the valve between the right atrium and right ventricle actually does not exist. So the only way this child is having any blood flow at all is through an ASD. The foramen ovale, which is, if it stays open, we call it an ASD, and the PDA, these two things must stay open, or this child will not be able to oxygenate at all. So this child will probably get PGE to help keep that PDA open. Let's see. Let's look at the picture. There you go. So the deoxygenated blood mixes with the oxygenated blood, and that is the problem. So when you look at this here, you can see there's no opening here. There is the foramen ovale that becomes an ASD, and then here's the PDA. This is that tunnel between the pulmonary artery and the aorta, and you want some of that oxygenated blood to come back down. It's one of the few things that keeps that child alive, because see how they have all this deoxygenated blood? That will also come down in here. Oh, I am so sorry. And go back into the lungs. Okay. These kids will have tachypnea, and they'll have difficulty feeding. So obstructive disorders, these have a narrowing of some major vessel in the body or in the heart. It impedes the blood flow, and it also can cause some problems with peripheral circulation to the lungs. This will back up. It's sort of like, you know, after you watch a movie, everybody kind of stands up at the same time and tries to get out the door. And if only one door is open, it takes a long, long time. Everybody's backed up, and they're noisy because they're talking about the movie or where they're going to go to eat or whatever. But if you open the second door, everybody starts to move out slowly, and the noise quiets down, and it just goes along, right? So that's the thing. The pressure, when it backs up, right, it takes a little bit longer. If there's an obstruction or a narrowing, it takes longer, and the blood, just like people in the movie theater, kind of collect and back up. Okay. So let's talk about coarctation of the aorta. I'm going to go to the picture. So here you have the narrowing. You can see it right there. So there's that door, right? One door is open, not two doors. So all the people are going to back up here through this aorta into the heart and the lungs. So the blood will do the same thing. It can't all get through. It'll clog it up, and it will back up. Now you have high pressure here, so it's going to be a problem to back this up, and this is going to make it even higher, that pressure on the left side. And when it comes back down the aorta, it's got to go against a valve that is meant to go up and not down, right? Then when it gets here, it has to go another valve, has to go against another valve that's meant to come down and not up. So very often it backs up and goes right through back into the lungs. So let's see. The afterload of the left ventricle is increased, and some kids, this can cause them to go into heart failure. So the symptoms depend mostly on the severity of the coarctation, how small it is. And some kids will get into school age before we find this, if it's not a very narrow problem. If it's like a door and a half open, it may take a while to find it. These kids will have increased leg pain, dizziness, fainting, and headaches. So think about the leg pain. If you're backing, you're not getting enough blood through here, right? It's not going. Only one door is open. Not enough people are coming through. Not enough blood is coming through. So what happens is, there's down here where the legs are, they're not getting enough oxygen. And probably that child's playing soccer, riding a bike, doing something. And the legs need more oxygen and they're not getting it. So cells start to die. When that happens, it's very painful. So these kids will have severe leg pain. They will also get dizzy because of the backed up business and the lack of oxygen. So let's see, what else can I tell you? Full bounding pulses in the upper extremities, absent or weak pulses in the lower extremities. Normally, your blood pressure is higher in your legs than your arms, but with this defect, the blood pressure will be higher in your arms because of everything backing up than it will be in the legs, right? Okay, so that's why we take blood pressure on all four extremities to see where it's the highest and where it's the lowest. Usually they will do an angioplasty for this, a balloon angioplasty via a cardiac cath. Sometimes there's a surgical repair, but not very often. They will cut out that coarctation and reanastomose it. Or if they cannot, they will take one of these blood vessels and they will overlap it so that that opening can close. Oh, sorry. Okay, let's talk about aortic stenosis. So this is also caused by a muscle obstruction below the aortic valve. It's actually an obstruction of the valve itself and a narrowing. Let's look at the picture. So here you can see, right, very narrow, this very tiny hole to go up. And imagine the pressure. You already have high pressure on the left side, but now you have this tiny, tiny little hole. So when you're trying to leave the theater, they're letting one person at a time through the doors. This is all going to back up, and it's going to be really uncomfortable and bad for this child. So let's see. When it doesn't function properly, the left ventricle has to work harder, right? This here has to work much harder to pump the blood up the aorta. And because of the increased workload, sometimes this will hypertrophy the left ventricle. If it continues and becomes a bigger problem, you can have a backup of pressure into not just the circulatory part of the body, but also it can cause pulmonary edema and work its way into congestive heart failure. Always assess the pulses for these types of problems. Okay, now we're going to talk a little bit about mixed defects. These are things that, defects that involve mixing of the blood so that it's very poorly oxygenated. Also, the systematic blood flow will contain a much lower oxygen level. And even worse, it decreases their cardiac output so that heart failure occurs. So let's talk about those great vessels and transposition. I'm actually going to give the picture. So I'm sure you can already see the problem here. These are in the wrong place, right? So we're having oxygenated blood going back to the lungs, unoxygenated blood going up over the aorta. This is a problem. What saves the child is this VSD. So there's some mixing. some of that oxygen actually can go up the aorta. So the aorta arises from the right ventricle instead of the left, and the pulmonary artery arises from the left instead of the right. So they will do a balloon I can't say that. Tipped catheter is passed through the atrial septum, and what they do is they try and enlarge that so they have better mixing of blood. Okay. Hypoplastic left heart. This is something, actually all three of these are something that children can die of if they're not adjusted quickly. So in this particular problem, all the structures on the left side of the heart are severely underdeveloped. They're very small or non-existent. The left ventricle doesn't function at all because it's so small. And there was a time when these kids did not survive. Now they tend to survive a little bit, and they have multiple surgeries. It used to be 5 or 6, now I believe it's 4. So these kids need to have their PDA open from the time they're born until they go to surgery. If that PDA closes, the heart cannot pump any blood through the systemic circulation, and the child will probably code almost immediately. This kid will die very quickly without surgical intervention. Okay. What else can let me go to the picture. There you go. Trying to think if there's anything specific. Nope. Okay, so here you can see that left side that really has not developed. This ventricle is so tiny, it really can't function. And you have nothing but unoxygenated blood going to the body. The the aorta, very, very small, and the pulmonary artery is a little bit stenosed. This is a big problem. Okay. So I'm going to talk about a little bit about cardiac surgery, and then once we get to the next slide, I'm going to stop this part of the audio and save it, and then start a new audio with heart failure. So cardiac surgery, obviously you want to monitor their cardiac output. It's very important to know how that heart is functioning and how or whether it's having any kind of output. Respiratory function support, this child will most likely be ventilated, and fluid and electrolyte balance is incredibly important. The electrolytes you're going to most pay attention to are potassium and calcium. You want to promote comfort for this child and obviously promote healing and recovery. I'm going to stop here and save this, and I will be back with the second half of this presentation.